Or to this computer. Perfect. All right, cool. Like this.
Yeah, I would think so.
Okay, cool. Okay, we're gonna start the review now. All right, cool. So, how are you guys doing? Everybody doing okay?
We're doing great.
Yeah. Um, so congrats on finishing CVS 2 and starting respiratory. I think out of all the IPCs from the first year, respiratory is definitely the easiest. So you guys have gotten over the hard part, and you guys can
It's a good one to
kind
end
of
with.
yeah, it's a good one to end off on. So you guys are gonna be chilling. So for this portion, we're gonna go over hypertensive crisis, advanced cardiac life support, and shock syndromes.
Mhm.
All right. So, just some symptoms of hypertensive crises. So, patients can experience dizziness, severe headaches, vision problems, nausea and vomiting, trouble breathing, and chest pain. So, typically, when patients come in and they're over, like typically 180 over 110, it's kind of like stuff that we see. That's very common. I think the most common is like the dizziness and severe headache. That's usually like what people feel when they have hypertensive crises. All right. So definition of hypertension crisis. So this is when our systolic blood pressure is greater than or equal to 180 over 120. And then so the difference between a hypertensive emergency versus hypertensive urgency is the new or worsening end organ damage. And the organs that are typically damaged by this are the brain, eyes, heart, the vascular system, and kidneys. All right. So when your blood pressure is super high, there's increased perfusion to these organs, and that increase in pressure can really do damage to those really tiny vasculature, especially like in the eyes. That's why people get vision problems. And in the brain, like the little vessels that are there, they can get damaged, which causes the headaches and pains. What is the difference in the treatment of urgency versus emergency? So in urgency, we don't require rapid lowering, but just gradual lowering over hours to days. In emergency, this is always an acute thing that we want to treat as soon as we can, and it requires hospitalization, monitoring, and IV antihypertensive drugs. Do you guys know what the most common cause of hypertensive emergency is?
I think Thomas.
Any guess? Yes, Thomas.
Timeout.
Timeouts.
He's got
You have two remaining.
two.
Any guesses?
Not taking your meds.
Perfect. Exactly, right? So when patients stop taking their antihypertensive medications, so like calcium channel blockers, especially, there's a rebound effect. Especially with calcium channel blockers. If somebody stops that abruptly, it's no bueno. Because if you think about it, right, if you're taking a calcium channel blocker, what happens is that your body makes more calcium channels, and they're going to be more sensitive because the body's trying to compensate for the medications blocking that system, right? So if you stop taking that, not only are you going to unblock those calcium channels that were already there before, but you're also going to have those calcium channels, the new ones that are more sensitive. So you're just going to get a rapid influx of calcium, and it's not going to be good. Alrighty. BP lowering goals. So, for our BP lowering goals, this is going to differ depending based on the condition. So, a lot of them are very similar. So, the way that I would know this is by going through the different disease states and kind of grouping them in a way that you can kind of remember. Um, So the goal is going to be very similar for a lot of these. What's going to differ is kind of like the medications that are recommended for them. All right. So in AKI, we want to reduce by less than or equal to 25% in the first hour, and then reduce to less than or equal to 160 over 110 in hours 2 to 6. Also, for treating AKI, we want to avoid enalaprilate and decompensated heart failure and pulmonary edema. We want to reduce by less than or equal to 25% in the first hour. We want to reduce to 160 over 110 in hours 2 through 6. We want to use nitroglycerin or nicardipine. And then we also want to avoid beta blockers and non-DHP calcium channel blockers. All right. In aortic dissection, our goals for systolic blood pressure is less than 120 within the first hour, but ideally want to lower it less than 120 within the first 20 minutes of seeing the patient. Our target heart rate is less than 60 beats per minute. We want to initiate a beta blocker, then a vasodilator to prevent reflex tachycardia. Right. So once we start that beta blocker, the body's going to try to compensate to increase that cardiac output by causing tachycardia. So we kind of want to stop that before it happens. So the reason why we want to have a low systolic blood pressure and decrease the heart rate is because we were trying to prevent the aortic the aorta from tearing, right? So a dissection is when when the two luminum kind of like separate from the vessel. And it's kind of like how you see in this picture here. There's like this little separation. If the hypertension and increased heart rate continue, the aorta can completely rupture, and the patient will die pretty quickly from internal bleeding. For an intracranial hemorrhage, if the systolic blood pressure is greater than 220, we lower and monitor. If it's 150 to 220, we want to lower to less than 140 in 60 minutes.
And just to kind of add, like these little images that are on the slide, like some of them may like seem silly, but these ones specifically, like with the symptoms and stuff like that, can actually be really helpful because a lot of the things like, okay, weak or absent pulses, shortness of breath, these are all like non-specific symptoms that can be seen in, as you know, a lot of different conditions. So kind of having it in these little funny charts to help remember some things where if you see multiple of these that are occurring at the same time, it can kind of help when you're doing like differential diagnosis on a patient. So some of them are funny in here, but like these ones are actually pretty useful that you can use not only for this class, but for other classes as well. So just keep that in mind.
Yep. Yeah, exactly. Because like on an exam, they're not going to always tell you like, oh, patient shows up with aortic dissection. It'll be like, oh, this person is showing up with like chest pain or abdominal pain. And then like it might say that the lumina is like separating from the blood vessel or something like that. All right, next is ischemic stroke. So remember, ischemic stroke we covered last time, right? So if they're receiving a fibrinolytic, you want the blood pressure less than 180 over 110 before initiating. And then during fibrinolysis, you want it to maintain it less than 180 over 105. If the patient is not receiving a fibrinolytic, we want to decrease the systolic blood pressure to less than 220. And to do this, we use nicardipine and labetalol. For hypertensive encephalopathy, our goal is to reduce by less than or equal to 25% in the first hour, and then reduce to 160 over 110 in hours 2 through 6. And then in this condition, most antihypertensives are acceptable. Okay, now talking about ACS. So it's kind of the same goals as we had before. We want to reduce by less than or equal to 25% in the first hour, and then reduce to 160 over 110 in hours 2 through 6. Antihypertensives that are used are esmolol, labetalol, nitroglycerin, and nicardipine. Caution with non-DHPs, non-DHP CCB. Sorry, that should be a DHP, not DHB. calcium channel blockers. So when it comes to like this kind of situation where we can use multiple drugs, they might give you multiple drugs that are potential correct options, but there'll be something in the patient case that will rule out one of the options. So like if there is an option for labetalol and nitroglycerin on the same thing, what might be something that could be included that would kind of rule out that nitroglycerin portion? Feel free to type in the chat or to shout out.
Sorry, just repeat it.
So in a patient case, what's something that could exclude nitroglycerin as a potential option? Yeah, exactly, right. So if a patient is on a PDE5 inhibitor, like sildenafil or tadalafil, something like that, that would rule out us being able to use nitroglycerin. All right. Okay, moving on to retinopathy. If we want to reduce the blood pressure to less than 25% in the first hour, reduce to 160 over 110 in hours 2 through 6, and then most antihypertensive agents are acceptable. We want to avoid phenoldiazepam in this condition. So if so say the patient's like blood pressure is like 170 over 110 or something like that, and it's not like that high. We still just want to make sure that we're getting to at least 160 over 110 in the first hour. It doesn't necessarily have to be like that 25%. All right. Now moving into advanced cardiac life support. Before we move on, I just want to let you guys like know, unfortunately for like the hypertensive crisis kind of stuff, it's kind of you just gotta look at it and memorize it. Unfortunately, there's no like real like there's no fun way to kind of do it. You gotta just sit down and memorize it. There's no like algorithms. Like at least for like cardiac life support, there's like this algorithm that you can follow, and it kind of makes sense of what you do and why you do it. Unfortunately, for that stuff, you kind of just have to sit down and memorize it. It sucks, but yeah. All right. So key concepts for advanced cardiac life support. So here we have a heart getting arrested, right? We got cardiac arrest. So high quality CPR is the most important thing for our patients. So we want 100 to 120 high quality compressions. So I think this was like a fill in the blank, I think, for our exam. It was like what's like the most important thing in ACLS, and it's high quality chest compressions. If you just put chest compressions, that wasn't good enough. You have to put high quality chest compressions. All right. The acronym that's really important for this is CAB. So that's circulation, airway, and breathing. All right. These are three things that we are trying to maintain in our patient. Right. The reason why we do chest compressions is to make sure that they're getting appropriate circulation so that oxygen is still getting out throughout the body while the heart's stopped. We have to make sure that the patient's airway is protected, right? So the way that we usually do this is by putting in like the trach tube, right, to the patient's throat, make sure that their airway is secure. And we also want to make sure that our patient is breathing, right? Usually like like if you see somebody go into cardiac arrest, we're going to do something called BLS, right? Basic life support, where we can't really do anything about the patient's breathing, right? It's not recommended to like put your fingers in somebody's mouth and do all that stuff. That's for advanced cardiac life support. So like if we see somebody pass out, right, we just do chest compressions to do circulation. We want to look to administer epi as soon as we can. And if we can't administer medication IV, what's the next best option?
IO.
IO. Yep, very good. So it's into the bone. So some nasty stuff. I don't know if they showed you guys a video of them doing an IO line. Did they show you guys that?
No.
No?
Yeah.
Yeah, it's
You guys are lucky for
oof.
that one. It's a little.
It's a little
It shows the
they showed oh yeah. Yeah.
Yeah.
That's cool. It's interesting. So what's the difference between basic life support and advanced cardiac life support? Who can tell me?
Oh, you-
Yes, was just like impressions. And ACLS. It's not something I know how to do.
Right. So Tommy kind of got there, right? So basic life support is just doing chest compressions and using the defibrillator. Advanced cardiac life support is when we start using the drugs like the epinephrine and stuff like that. All right. So BLS algorithm. Um, so here's kind of just like different steps that we do, right? So we want to verify the scene is safe. We want to check for non-responsive victims, uh, activate the EMS through like a mobile device or something like that. Check the patient's pulse. You want to begin the chest compressions, right? Look for an AED as soon as you can. Get those pads on. Check for rhythm and see if it's a shockable rhythm. So what are the two kinds of shockable rhythms that we shock?
VFib, VTAC.
Very good. Yep. So VFib and VTAC. Remember, it's always the ventricle. Never shock anything in the atrium.
Mhm.
All right.
Yeah, that's good. She said not asystole too.
Right. Yeah. You don't shock it. Yeah. Don't shock asystole. All right. Advanced cardiac life support. So here we see the different drugs getting incorporated. So first we start CPR. Of course, that's the first thing that we do. If we see somebody collapse and they're going the cardiac arrest, we always do chest compressions. If they have a pulseless electrical activity or asystole, we do CPR and we kind of go through like the stuff with the defibrillator. Just put the pads on, just keep doing chest compressions and hope that the heart rate comes back. Another thing that we talked about in class that I remember is that if you ever have pulseless electrical rhythm or activity, always make sure that the pulse monitor is on because like sometimes it can fall off the patient's finger, right? Or something like that. So you can see like the electrical waves, but their pulse will be zero. Make sure that the pulse monitor is actually on the patient. So after one shock, you resume CPR, you recheck the rhythm, and after you resume CPR, you look to administer epinephrine. We recheck the rhythm, just keep giving epi, and then we'll move on to like something like amiodarone or lidocaine. We always want to treat our reversible causes, and you just like keep going through the circle, right? So every 2 minutes, every 5 minutes, just keep going the cycle. Do epi, chest compressions, epi, chest compressions. Keep
one
going.
thing that like kind of really stuck with me, which I'm sure that they mentioned for you guys too, is like that something that's different about this algorithm is that it's not just like a line that just ends at the very end, but that it is actually a cycle. So, if you've already tried something and you have a certain question, like on a test, know that some of these things like may be repeated if it's not working, right? So that's just something to keep in mind. And you could see that, like, I know I'm a very visual learner. That's something that just looking at this image, you could see it's kind of just a circle and all of these arrows are, there's not an actual end to it. So the end is hopefully getting that patient back to, yes, exactly. So just keep that in mind that this is a little bit different from other algorithms and that we're trying everything that we can to bring that patient back.
Mhm. Excellent. All right, so dosing. So what is the standard dose for epinephrine? That's 1 milligram IV or IO every 3 to 5 minutes. I'm not sure if in your slides Dr. McMath may have given you guys like an actual like weight-based dose because I know that like sometimes no. So yeah, so just know whatever they told you. So I saw in our slides it was 1 milligram IV or IO every 3 to 5 minutes. And just keep giving it, and hopefully they respond to it. And then just know the doses for the amiodarone and lidocaine. Those will be probably one question each. So just know like, hey, if we already use amiodarone, we go to lidocaine, or if we already try lidocaine, we try amiodarone, and just know the doses. Unfortunately, that's you just got to know the dose for Dr. McMath. All right.
Before I go over like shock symptoms, does anyone have any like questions on that?
You can go over any questions
Yes,
you guys
just
have.
like stop.
Anything.
Just stop me. Nope. Okay. So shock syndromes. Let's talk about it a little bit. So I kind of like to think about this in terms of the cause first, because one of the things that I don't know if they mentioned to you, but shock is never something that just happens. It's always secondary to another condition, whether it's, initially occurring in the heart or whether it's something that's extra that's happening in the extracellular compartments, right? But it's always secondary. So the first thing that we want to do, kind of to break down an algorithm, which I'm going to show you guys later, which I know that these algorithms can be like scary at first when we're looking at them. So I'm kind of breaking it down into steps here on like how you would approach it for a case. The first step is to really identify what the actual cause is. So I already have them listed on here, but I kind of broke some of them down into more simple terms to help understand exactly what's causing each one of these. So we have hypovolemic, which is, a decreased blood volume. So does anybody kind of want to describe for me what would we see in a patient case that may jump out and say that a patient is hypovolemic? Any ideas?
They like dehydrated. Yeah, they have that look. You pinch their skin and it stays up. They've got like kind of sunken facial features, and or maybe they're not urinating a lot.
Dehydration for sure. So you guys are thinking more like in terms of like interstitial fluid, like in general. I'm also, that's not wrong. Additionally, like things like just trauma, right? Anything where you have like decreased volume of your actual whatever's in your blood supply, right? So trauma, any type of hemorrhage, where we're concerned about like bleeding being a cause, right? So it makes sense just thinking about it. If you have something where bleeding is happening, that would result in decreased volume. So those are some examples there. And we'll talk about, just a reminder of certain terms like preload, cardiac output, and afterload in a bit. But these are some things where you may see like decreased stroke volume, decreased preload. So just kind of keep that in your mind there. Cardiogenic. So this is where there's something that's actually wrong within the heart. The heart is a pump failure. So it's not something that's occurring outside. It's an intrinsic issue within the heart. So anybody want to throw out like some key things that may be happening here with cardiogenic shock? What'd you say, sir? Yeah. And MI? Yes, exactly. Both of them. Arrhythmias, MIs, anything where we see decreased contractility of the heart, right?
They flutter.
Yeah, exactly. Third one is obstructive in nature. So this one, there's still an issue, but the issue is now outside of the heart. So it's not a pump failure. It's some type of physical blockage that's occurring, not within the heart, that is going to alter these different factors that we talked about with preload, afterload, and cardiac output. So there's one specifically that I'm thinking of that's a huge, like, major cause of obstructive shock. Does anybody remember the pulmonary embolism is the major one that we see? Of course, there's other things that can cause it, but in terms of like your exam and what you would need to know, I would say that pulmonary embolism is the main one. And then this last one, which can kind of be classified as two different things, either vasodilatory or distributive, you may hear it called. This one, I always kind of like get questions on. So I would talk about this one in terms of systemic vascular resistance. So does anybody kind of want to explain what exactly is going on here? Because it's not a blockage. It's not an issue with the heart. You know, we may see that their actual blood volume is fine. We're not concerned about bleeding. So what's actually going on in distributive shock? Why is it an issue? And if you guys don't know, I can explain.
It's just like all around, and that just affects all the organs too.
So it is more like peripheral based usually, but what's actually happening is you have your blood vessels that may become dilated for a reason. And there's different things that can kind of bring that about or cause it, but that increased dilation is kind of going to cause your blood pressure to plummet. So it's something that's what we talk about with SVR, the vascular resistance, that's causing that extensive issue throughout the whole body. It has to do with the actual dilation of the blood vessels, and then boom, blood pressure decreases.
So what's one situation where that can happen? We've been talking about it pretty frequently.
Would that be like anaphylaxis?
Not what I'm thinking of. No, it's Medicaid, a drug interaction.
Oh, nitro and the
That.
Yeah, very good. Yeah, so it's a PDE5 inhibitor and nitroglycerin.
Yep.
Very good.
Yep.
Yep.
Hypotension. Okay, so that's step number one. Before I move on, because I'm kind of going to be talking about these throughout, does anyone want me to like stop and re-clarify one, or does that kind of make sense how we're breaking up our different types of shock? Good. I see thumbs up. Good. Okay, so identify it first. So now, thanks. Let's kind of go over, I kind of gave you a little word bank here. But I want you guys to kind of identify the primary dysfunction with each type of shock syndrome. So these little lines that you see here, like fill in one of the words. Now, all of them are going to mainly be affected, but each one of them kind of has a primary issue. And let's just kind of go over which one is primarily affected by each and whether it's going to be increased or whether it's going to be decreased. So let's do the first one. Hypovolemic shock. What do we think is mostly going to be affected? Preload, cardiac output, or afterload? Yeah.
preload.
Preload. Up or down? Down, right? Because that's the initial amount that's going in. Good. Cardiogenic. Cardiac output, yeah. Down, yeah. You're right. Because if you have something like an arrhythmia that may be happening, right, the primary issue is within the heart itself. So it's cardiac output, and that will be decreased. Now, I'll talk a little bit later, like, don't let it fool you if we're talking about like decreased, a lot of things that are decreasing. So obstructive. This one's kind of a little bit weird, but
is it also kind of dependent on where the obstruction is?
a little bit. Again, all of the different things are affected. So we're going to see that afterload and preload are affected, but the primary issue is going to be cardiac output decreasing for this one. Mostly just because you have something external that's going on that's placing more pressure on the heart. So it's going to kind of decompensate for that. So that's the main thing. Again, I believe that they should have shared like a chart with you on different like up and down arrows for this. So that's not to say that preload and afterload aren't affected. It's just the primary one for this one is cardiac output. And then distributive. Also, if you're on Zoom, feel free to shout it out. You know it. So distributive is afterload, and it's also decreasing. So I kind of tricked you by putting the up arrows a little bit. Sorry, but it's all of them are really decreasing here. So just kind of to emphasize that with distributive, again, we see that systemic vascular resistance is the major issue. So afterload in this case is going to go down.
Can I ask a question?
Yeah.
Just for like distributive, because I'm just having trouble understanding why it's afterload and not afterload and preload. Because if like the entire like peripheral vasculature is expanding, wouldn't that affect both the incoming and outgoing pressure?
It does. Again, So preload is also going to be affected. It's kind of just, it's weird in terms of like how they define it. But it's kind of the one that's mostly affected, if that makes sense. So yes, you're right. Preload is also affected by this too. But if they do ask primarily which one, we do see more of an effect on afterload.
And also
Okay.
remember, in venous return, right? The veins have what, like the regurgitation system that like prevents it from regurgitating, right? So it has like the valves, right, to help it move forward. So even though the veins are going to be dilated a little bit as well, it's not as bad as in the arteries, where the arteries don't really have anything to keep that going. The veins have that system to help support it and kind of like prevent that, you know. So in even though preload may decrease, it's that afterload decrease that like that's really like the problem because there's nothing to like, you know, it's like
It's purely based on that.
Yeah.
that dilation of the arteries that we're
Yeah.
really
And
worried
the
about.
arteries have like more to lose than veins because
Exactly,
veins
with
are
that
already so
support.
compliant.
Exactly.
Yeah.
Right.
Okay.
Perfect. Yep. You got it.
Does that help? Okay. Next, let's see. Okay. So there's kind of three main, I won't really say classes of drugs because one of them isn't really a class, but kind of treatments that we can consider if you have somebody with shock. What are the three main things? And they can be in any order. There is an order, but for our purposes now, I'll take them in any order if you only remember one. What can we consider in terms of shock? Like if somebody presents, what are some things that we may want to initiate now for a patient?
That's
Vasopressors is one. There's a kind of another like class of drug that goes with that. Do you remember what class that is?
Some pathomimetics.
So like your ionotropes, right? So any of your ionotropic medications. And then the last one I'm thinking of, again, it's not really a drug class, so you may have been thinking about this, but it's IV fluid resuscitation, right? Which is especially going to be important for our patients that are hypovolemic, right? So in terms of the order, I'll go over it once we actually look at the algorithm, but we're going to be looking mostly at the fluid resuscitation first, and that'll make more sense once I get to that slide. So when you're looking at a case, there are certain things that we can look at in order to see if there's evidence for end organ dysfunction as well. So one of the main markers that we talk about is lactate. This is going to be super important. I feel like it pops up in a lot of different cases. So definitely know this cutoff of like lactate greater than 2 can be evidence of any type of end organ dysfunction. So in terms of labs, kind of keep this in your mind that we're looking at, you know, things like platelet count, we're looking at urinary output. And this is going to be important as we start treating the patient. We can kind of look at these different lab values and parameters and say, okay, well, is our treatment actually working? You know, are they regaining that urine output if it was decreased? Do we see that their lactate levels are going back to normal if they were elevated? Some things that aren't really listed on here is like mental status as well. We may see that patients present with like dizziness, confusion, altered mental status. So that's something that we can sort of mark as well if that's either getting worse or it's starting to get better. So keep that in mind that there's actual lab values, and then we can look at how the patient's actually presenting as well. And also I have on here MAP, mean arterial pressure. Know that cutoff of 65. I feel like that's just super important. That always comes up.
Know the formula too, because they're not going to give it to you.
Yeah, if they have you calculate it, just keep the formula in mind. I don't remember on this exam if we had to calculate it.
I know we think we did for like the second one or the first CVS 2 exam, but I'm not sure if we had to do it for this one.
Yeah.
Are you good to move on?
Yeah. Oh, and one more thing. So what clinical symptoms can we look for in a patient? Another thing is like capillary refill. I believe if it's like greater than 3 seconds, then that can be a concern for these patients. Things like tachypnea as well. So looking at respiratory rate, all of those parameters in our lab values. And things like if our patient presents with like a really high heart rate, that may actually happen, which you may think, okay, it's shock. Why would their heart rate be elevated? But again, it's kind of compensating for what's going on. So it wouldn't be uncommon to see a patient actually present and be tachycardic in these cases.
Right. And which form of shock do you guys think that would happen like the most in, that you would see that increase in heart rate?
Like hypovolemia.
Yeah, it can happen in hypovolemia. I was thinking more of and distributive. Yep, because we're gonna have that really big decrease in preload as well. So both answers would kind of work, right? So if you're having less of that preload, your stroke volume is going to decrease. So your heart is going to be pumping more to try to get more blood through the heart, right? So it's going to just keep pumping and pumping and pumping and increasing the heart rate. Yep.
Okay. Good. Any questions on any of what I just said? Okay. Okay, here's the beautiful algorithm that I prepared you all for. So first thing that we want to do is kind of break it down because we've already talked about what we've talked about fluid. We've talked about vasopressors. We've talked about our ionotropes and other extra medications, right? That we can kind of do not first line, not even second line, but kind of considering afterwards, right? So that's really what they're saying here in this case. So the first part, signs and symptoms of shock. So that's if they're presenting with, we see that systolic less than 90. We see that mean arterial pressure cutoff, right? So we're less than 65 in this case. So if we see that in a patient, right, we should automatically have alarm bells going off. Okay, there's something definitely wrong. So then first thing that we want to do, since I mentioned that there's kind of an order, is we do that fluid resuscitation test. So we can give it, if some patients, first of all, they maybe are contraindicated to that, or it wouldn't be ideal in their case. But usually we can give like a fluid challenge, they call it. And either they're not responding to it and we don't see that their blood pressure is, going back up to where it needs to be, or they respond to it and that's great. But that's like initially what we're doing before we even consider something like a vasopressor, right? So vasopressors, yes, they're great, they work, but we try this first, especially for any type of like hypovolemic shock, like maybe this is all that patient needs, right? So try the fluids first. Then you can kind of see in this like second line here, then if they aren't responding to that, then we can consider our vasopressor. And I know like this is up on the thing, but what is our preferred vasopressor for our patients?
Norepinephrine.
Norepinephrine, yeah. An important kind of point to make with norepinephrine, what's something that we want to monitor with norepinephrine? So why aren't we just like starting off with norepinephrine? I don't know if he mentioned this to you, but it's important to kind of know. It's risk of like ischemias and things like that. So just in case that comes up, I'm not sure if they'll ask that, but just in case, that's why we want to monitor it. And that's why we're not really giving it right away. So then after that, then we can look at, different things like evidence for inadequate cardiac output, considering stuff like the echo to see, is there something that's actually going on within the heart? So it's kind of like ruling out different components, if that makes sense. It's nothing like different than what we've been talking about. It's just this funny little algorithm of how they include everything, but don't let it like scare you. It's just break it down into the different sections. Like, are we giving fluid? Is that working? Yes, no, we're moving on to the next step. Okay. Does that kind of help break this craziness down a little bit? Good. Okay.
And again, kind of like how I said before, think of it as a cycle, right? And I think I mentioned this kind of like the last review session that we had too. In acute care, they have to make stuff a cycle because you have to constantly doing something to like try to help the patient. You're not just gonna say, okay, we gave one dose of epinephrine, patient didn't respond, that's it, we're done. Right? That just doesn't happen,
Yeah.
right? There has to always be something that you can try next. It's just a big cycle, a big circle, and eventually, hopefully, the patient responds.
Mhm.
Very cyclical.
So here's like a little case. Again, Serena, for those that know Serena, she really just wanted to be in the case. I'm like, it's not a good case. Like it's shock here. It's not going to be something good. She's like, I don't care. Please include my name. So we did get approval from Serena for
We
this.
got to try to save her.
Okay, so please save Serena, brought to the emergency department after a motor vehicle accident. We see blood pressure is 78 over 46, heart rate is 132, respiratory rate is 28. You see cool, clammy skin, capillary refills greater than 3 seconds. There's a decreased urinary output. We have our hemoglobin levels of 8.5 and a lactate of 4.8. Okay, so just from looking at those labs, does anyone want to shout out one that they're like, oh my goodness, that's not good? Which one? Yes, hypovolemic. Why are you saying that?
Decrease urine output. I think the capillary refill, like that just stuck out to be little.
Yeah.
I don't even know if that's actually one.
No, yeah, no.
Vehicle accident.
Motor vehicle accident. So we have a sign of trauma where there can definitely be bleeding that's going on. There's actually a lab value here. We see hemoglobin's really low right now. So that should be a sign right there. Okay, we have hemorrhage going on. This is most likely going to be the hypovolemic one. Looking at heart rate, what are we thinking? That's high.
Pretty high.
Yeah, that's high, right? So that's that compensation that's going on. So they're tachycardic. Respiratory rate is, a little bit like more on the elevated side. Decreased urinary output. Again, that was one of the markers that we talked about for end organ damage, right? So that's something that we can monitor to see how they're doing in the future. What about that lactate level?
That's too high.
That's too high, right? What was our cutoff again? 2. So all of these things that we see, again, blood pressure, the 78 over 46 is, we're not really liking that too much either. So we already did number 1. So what's the first thing that we're going to do? How are we going to help this patient now? Fluids. Let's try fluids. And then if fluids don't work, then we can consider, you said it before.
That includes
Anybody else know if you kind of do just go through the algorithm, right? So like assess fluid responsive, then we can consider your vasopressors, right? But we're not like, I wouldn't just start off with norepinephrine right away. Like try the fluids first. What type of fluids are we starting? Like what? Crystalloids.
Lactated ringers.
Okay, for those that couldn't hear, normal saline, lactated ringers, your crystalloids. I don't know if they went over with you, but there's a rate of administrations for some of them that you could start with. It's 30. Yep, it's 30 milliliters per kilogram of an IV crystalloid fluid. Okay. And kind of what are our goals of therapy that we want to be going through? What are some things that we're going to be looking at here? I kind of already mentioned some of the big ones, but like I mentioned, urine output is something that we can monitor. What's another big thing that you may need to calculate that we can monitor? Mean arterial pressure. Yep. And monitoring the lactate, making sure that goes back down into our normal range. And we don't really have like information in this case on this, but right, Serena could be a little bit confused, a little bit dizzy, right? So seeing just like the status of the patient, and like mental status, like change in mental status is a big thing here for shock as well. So we could see if that changes as well. Anything else that I missed that you guys kind of want to talk about specifically from this case? I think we kind of hit the majority of the lab values, but any questions either here or here?
One
Yeah.
quick question. I remember him mentioning something about when to use like isotonic versus a balanced salt solution, and I think that had to do with like TBI. Like if there's a risk of TBI, you want to use a balanced salt solution.
Yeah, it's almost like if you're using something like a 0.9% normal saline solution, I believe, um, and you have somebody with a TBI, then it can actually cause more harm. So that would be something where if it's in the case, you're actually at an increased risk for like cerebral edema and things like that. So I think that that's like the only kind of specific um exception that they would have and for which one would be preferred or not. At least for this exam, I believe that's the only one.
Yeah, I was gonna ask you guys. So, like, what would a high lactate level do to the blood? There's something that it changes in the blood. You guys know what it is? I don't know if they covered it in CVS too, but I'm pretty sure you guys covered it with Dr. Sun and Renal. Yeah, but what does it do to the pH?
It's lactic acid, right? So it's gonna,
Right, so it's gonna cause the pH to go down and become more acidic. Right, so if I have the option to use normal saline or lactated ringers, which one would I use?
same. Oh,
Mm-mm.
lactate ringers.
Use lactated
Lactated
ringers,
ringers.
right? So lactated ringers is gonna buffer the pH. So that's kind of like another situation that we'd kind of want to choose one over the other. Yep. Because I believe lactated ringers breaks down to bicarb in the
It
body,
does.
and that bicarb is going to act as a buffer.
Like it's a small amount overall of the
Yeah.
bicarb, but it's something that potentially, if you're choosing between one or the other, we can go with the lactated ringers in that case.
Yep.
Yeah. Yep. Okay. Does that help? Any other specific questions or things that we wanted to talk about from this case? Okay. Okay. And again, this is just like another way of kind of looking at it, right? So fluid resuscitation first. Again, we want to try to get that stroke volume, cardiac output, and blood pressure back to our normal ranges. We mentioned that if it's distributed, we're starting out with that 30 milliliters per kilogram of the IV fluid. And then again, there's more specific requirements if you are hypovolemic. Typically, we give this in smaller amounts for if it's in order to kind of get that pulse back where we can feel it. If you can't, a lot of it kind of depends on the physical exam specifically. And then based on that, if the volume resuscitation is not working or if it's not indicated for the patient, then we can try on the vasopressor. So again, it's mostly just knowing kind of the order on when we're trying out certain things. I included here at the bottom kind of dose ranges for norepinephrine because that's the main one that we talk about. So I would definitely know these because they like to ask the doses unless they specifically told you something different. They like to assess the
They like to
doses.
access the doses a lot. Huh?
Yeah,
They
they
like
do
their
like their
doses.
doses. And we kind of went over the other things that I include here on the preferred vasopressor being norepinephrine, and then our monitoring parameters we really already covered for risk of ischemia, things like that. So that's any questions specifically? You guys good? Okay, good. That's all we have. So we're a little bit early, but as always, if you guys have any questions, please let us know. I hope that this helped.
Yeah, do you guys have any other questions
Yeah.
about anything from this stuff, the second exam, first exam?
Yeah,
Any concerns?
so I think this is cumulative for you guys.
Yeah, right. It's cumulative.
Yeah.
Yeah. I cry every time.
Yeah.
I mean, only like 10 questions are gonna be like from exams 1 and 2.
Yeah.
Oh, okay.
It's fine.
That's not bad.
So
Yeah, those
if we
will
get
probably be
all-
like big picture questions too. So like
Yeah.
anything that's like bolded, I would just like look at the bolded stuff. I wouldn't.
Yeah.
The way I see it, like if we get all 10 of those wrong, you get the other 40 right. You get 80.
Mhm.
It's not bad.
There's
They're only 40 questions.
There's only 40 questions. What?
I thought it was
No
50.
way.
Yeah, just
How are they
I
only
thought
doing
it was
50 questions?
80.
I think our final
It's 50.
our final had like 86 questions
Mhm.
for neuro.
For neuro.
Yeah.
Yeah.
And psych had like 80 something questions too. right? Or no, 60.
It was
They'll-
60.
They'll just stick in.
Yeah.
That's what they do.
Right.
Oh, Lord.
Well, if anything comes up,
Feel free to email us. Me and Emma will be
let
here.
us know.
Emma and I.
Yes.
Thank you.
Thank
Of
you, guys.
course. See you guys in a little bit.
Bye.
Bye.
You guys are-
Yeah.
Thank you.
Thanks.
I had that